This is Professor Nicholson lecturing on applying the nursing process to the care of the postpartum mother and her family. Please review Unit 4, Module 1 Subcompetencies on your own. Postpartum. This is the critical transition period for woman, newborn, and family, physiologically and psychologically. Note that we will be discussing the physiologic transition in this lecture. The puerperium is the period after the delivery of the placenta. It lasts 6 weeks. This is considered the 4th trimester. So in case you see this word, this is just what it means. Please take a look at the document I posted to Blackboard for this unit and module. It really does go in depth and explains bubbly very well. Fundal assessment. Know that as a nurse, you need to put your non-dominant hand over the symphysis pubis. Why? This supports and anchors the lower uterine segment. It also prevents uterine prolapse. This is an obstetric emergency. It would require the provider to push the uterus back inside with their fist because the uterus comes outside of the vagina. The uterus cannot contract and firm when outside of the body. Therefore, this is a hemorrhage risk. Also, please note when you are doing fundal assessments, lay your patient flat on the bed. Uterine involution involves 3 retrogressive processes: contraction of muscle fibers to reduce those previously stretched during pregnancy, catabolism, which reduces enlarged myometrial cells, and regeneration of uterine epithelium from the lower layer of the deciduous after the upper layers have been sloughed off and shed during lochial discharge. The factors that facilitate uterine involution include complete expulsion of amniotic membranes and placenta at birth, complication-free labor and birth process, breastfeeding, as well as early ambulation. You need to know that this occurs quickest in a primipare patient due to the uterus being able to maintain a contracted state better than a patient who has birthed multiple babies. That uterus really works hard. So why does involution occur immediately after birth and delivery of the placenta? Well, because the uterus begins to contract in order to constrict the intramyometrial vessels and impeding blood flow. This is the primary mechanism preventing hemorrhage from the placental site. Yes, there is even bleeding after a C-section. You should always educate this to your C-section patients. Because remember, the bleeding is due to the healing of the wound within the uterus from the placenta. Also, you do need to know that bleeding is expected to be less postpartum for a C-section patient versus a vaginal delivery. This is due to that manual extraction of the placenta during the surgery. Again, think of the healing process as like a scab. Think of the colors of a scab as it starts to heal. Subinvolution. This is the inhibition of involution, which results in uterine atony. Atony can result if the uterus does not contract properly after birth, which is a serious complication that can result in postpartum hemorrhage. Factors that inhibit involution include prolonged labor and difficult birth, incomplete expulsion of amniotic membranes and/or placenta, uterine infection, overdistension of uterine muscles, such as if there's a multiple gestation, so twins or triplets, polyhydramnios, which is a lot of amniotic fluid, or even a large singleton fetus. Other complications are due to a full bladder, which displaces the uterus and interferes with those contractions, and any anesthesia, which relaxes uterine muscles, making it harder to stay toned. And of course, close childbirth spacing, so maybe somebody has a baby and then has another baby within the next year, which is possible. Checkpoint. What is the priority assessment for a patient who is administered a pain medication postpartum due to those after pains, so that cramping? You need to reassess pain per protocol. This is so important. You want to ensure the nursing intervention was successful. Any medication given to a patient needs to be assessed per policy. You should also know that pain is the priority assessment for a patient that has had a cesarean section. Think about it. It's an abdominal surgery. The picture on the left over here is what a cervix looks like, prior to delivery. After delivery, it's no longer circular, but it appears to have a jagged-like slit opening, like right here. The cervix typically returns to its pre-pregnant state by week 6 of the postpartum period. This is why providers tell their patients they should not have any sexual intercourse until that 6-week checkup appointment, because this is an infection risk. Just to look a little deeper, the internal os, which is the inner portion within the cervical opening, this gradually closes and returns to normal by about 2 weeks, while the external os, so the opening that's closer out here, never appears the same after childbirth. I wanted to show you what an internal and external os looked like because you might hear providers talk about this during your labor observations. Lochia passes through 3 stages. Lochia rubra is a deep red mixture of mucus, tissue debris, and blood that occurs for the first 3 to 4 days after birth. As uterine bleeding subsides, it becomes paler and more serous. So Lochia serosa is the second stage. It has a pinkish brown appearance and is expelled from days 3 to 10 postpartum. Lochia serosa primarily consists of leukocytes, decidual tissue, as well as red blood cells and serous fluid. Lochia alba is the final stage. The discharge is creamy white or light brown and consists of leukocytes, decidual tissue, and reduced fluid content. It occurs from days 10 to 14 but can last 3 to 6 weeks postpartum in some women and still be considered normal. Lochia at any stage should have a fleshy smell. Again, lochia at any stage should have a fleshy smell. An offensive odor usually indicates an infection, such as endometritis. I want you to know that lochia, if it ever all of a sudden turns into like a bright red appearance a week out from their delivery, they should really call their provider. This could mean that maybe there's some placenta still stuck inside, or that amniotic membrane. Also, educate your patients. Any clots bigger than a plum, let their provider know. Little clots are normal, but if you notice it's very frequently, you should really have them be reassessed by their provider. Checkpoint. When performing a postpartum assessment, the nurse notes a clot when checking the fundus. What is the most appropriate nursing action? I will give you a moment to think about your answer. So the answer here is C, fundal massage and call for assistance. So how do you call for help if you're in the middle of fundal massage? Push the staff assist button closest to you. Pull the emergency cord, whatever gets you that extra assistance. You do not want to stop massaging the uterus, as this helps firm and constrict those uterine blood vessels to prevent hemorrhage. Please review the postpartum danger signs on your own. Your textbook also gives great information on complications such as infection and hemorrhage that can result from these danger signs. I do want to emphasize that saturating a peri-pad in an hour is very important to educate your patients on during that postpartum period, as well as, like I mentioned in a previous slide, those large blood clots. I also want to emphasize that you should encourage patients to increase their fluid intake if they have an increased temperature. This is a very appropriate nursing action for postpartum patients because you want to encourage hydration to prevent insensible fluid loss during this time. Checkpoint. 2 hours after delivery, your patient is sitting on the edge of their bed stating, "I feel dizzy." Which nursing interventions are the most appropriate at this time? This is a select all that apply. I will give you a moment to think about this answer. The answers here are B, lay the patient supine, and C, obtain a blood pressure. The other interventions are not appropriate immediately at this time. The perineum is often edematous and bruised for the first day or two after birth. If the birth involved an episiotomy or laceration, complete healing may take as long as 4 to 6 months in the absence of complications at the site, such as hematoma or infection. The muscle tone may or may not return to normal, depending on the extent of injury. Perineal lacerations may extend into the anus and cause considerable discomfort for the mother when she is attempting to defecate or ambulate. The presence of swollen hemorrhoids may also heighten discomfort. Local comfort measures include ice packs, pouring warm water over the area with a peri bottle, witch hazel pads, anesthetic sprays, and sitz baths. I encourage you to allow privacy for your patients during this time, but also ensure they have no concerns. Ask open-ended questions and know that if they state a concern, you need to really truly visually inspect the area as a first priority. Some patients can be a little bit more modest than others, and they may just want their primary provider to take a peek at the area and not, all the nurses they see throughout their stay. But please ask them open-ended questions. Also, make sure you know about RETA, which I highlighted in purple within this slide. Pelvic floor tone may take up to 6 months. Pelvic floor dysfunction is one of the most common complications of childbirth following a vaginal birth, and it can have a significant impact on the woman's quality of life as she ages. Nurses should really encourage and educate the importance of pelvic floor exercises, such as those Kegels. Cardiovascular system adaptations. During pregnancy, the heart is displaced slightly upward and to the left. This reverses as the uterus undergoes involution. Cardiac output remains high for the first few days postpartum and then gradually declines to non-pregnant values within 3 months of birth. Blood volume increases substantially during pregnancy, drops rapidly after birth, and returns to normal within 4 weeks postpartum. An increase in cardiac output and stroke volume during pregnancy begins to diminish after birth once the placenta has been delivered. Therefore, the pulse decreases. This slowing of the heart rate is related to the increased blood that flows back to the heart and to the central circulation after it is no longer perfusing the placenta. Note, tachycardia is concerning because this could indicate dehydration, hypovolemia, or even hemorrhage. Blood pressure falls mostly in the first 2 days and returns to pre-pregnancy levels by 6 weeks. You should educate your patients on signs of preeclampsia, as this can happen during the postpartum period. A significant increase accompanied by headache might indicate preeclampsia, and that requires further investigation. Increased blood pressure may suggest an infection or even a uterine hemorrhage. Giving birth stimulates this hypercoagulability even more. This hypercoagulable state, combined with vessel damage during birth and immobility, places the patient at risk for thromboembolism. Hematocrit levels should remain relatively stable. Regarding red blood cell production, this ceases in the puerperal period, causing hemoglobin and hematocrit levels to decrease slightly in the first 24 hours. They then slowly rise over the next few days. The white blood cell count, which increases in labor, remains elevated for 4 to 6 days after birth. This can complicate a diagnosis of infection in the immediate postpartum period. I recommend you take a look at your patient's labs and clinical to see what I mean by this slight elevation. RhoGAM is a blood product. It's an IM injection that suppresses the mother's immune response and antibody formation against fetal Rh positive blood cells. It's important to know that RhoGAM needs to be given within 72 hours postpartum. Again, within 72 hours postpartum. Understand that if the newborn has a negative blood type along with the mother, it should not be given. However, if the newborn has a positive blood type, it needs to be given within that 72 hours postpartum. We know the baby's blood type because at birth, the provider collects blood from the umbilical cord and it gets sent off to the lab so that we can investigate if the mother needs RhoGAM or not. Urinary system adaptations. During the postpartum period, the glomerular filtration rate and renal flow increase. This slide shows how voiding sensation can be affected. I'm not going to read all of these, but just familiarize yourself with these possibilities. Failure to maintain and restore a perineal muscular tone can lead to urinary incontinence later in life for many women. Like I mentioned earlier, pelvic floor exercises are so important. Teach patients about those Kegels. Difficulty voiding can lead to urinary retention, bladder distension, and ultimately urinary tract infection. Urinary retention and bladder distension can cause displacement of the uterus from the midline to the right and can inhibit the uterus from contracting properly, which, as I mentioned earlier, increases the risk of postpartum hemorrhage. Frequent voiding of small amounts suggests urinary retention with overflow, and catheterization may be necessary to empty the bladder to restore that tone. An important nursing intervention you need to know is to allow time for the patient to ambulate as soon as able to after delivery, whether it be a vaginal or a cesarean section, and encourage them to void. If a patient has not voided by 6 hours postpartum, the provider should be notified, maybe even sooner, and a bladder scan is more than likely going to be implemented, and a possible straight catheterization to remove the urine, as I mentioned. I always find that running water, privacy, if the patient is safe, of course, and the smell of peppermint promotes urination. GI system adaptations during the postpartum period. So the GI system usually quickly returns to normal, and this is due to relief of pressure on the organs. There's also decreased bowel tones for several days and decreased peristalsis. This usually occurs in response to analgesics during labor, surgery such as a C-section, diminished intra-abdominal pressure, a low fiber diet, insufficient fluid intake, as well as diminished muscle tone. In addition, women with episiotomies, perineal lacerations, hemorrhoids, and even C-section incisions may fear pain or damage to the perineum or their incision with the first bowel movement, and they may attempt to delay it. Therefore, constipation is a common problem. A stool softener, such as pericolase, can be prescribed for this reason. They used to not allow patients to be discharged home until they had their first bowel movement, but some patients actually take a good week to have their first one, so they can go home now. Hunger and thirst is also something that occurs heavily in the postpartum period, and this is mostly due to that NPO or clear liquid diet status prior to delivery. Regarding the musculoskeletal system postpartum, joints return to pre-pregnant state except for feet. Women commonly experience fatigue and activity intolerance for weeks after giving birth. Abdominal muscle tone is also diminished, and special exercises are needed to return to normal. If the rectus muscle tone is not regained through exercise, support may not be adequate during future pregnancies. Good body mechanics and correct positioning are important during pregnancy to prevent low back pain and injury to joints. However, within 6 to 8 weeks after delivery, joints are completely stabilized and return to normal. Regarding the integumentary system, pigmentation fades as estrogen and progesterone levels decrease. Pigmentation includes that abdomen line, the linea nigra, the face, known as melasma, and nipples. Some women experience hair loss during pregnancy and the postpartum periods. Stretch marks fade to silvery lines. They do not disappear completely, despite those creams out on the market. Lastly, diaphoresis is common for about a week postpartum. It is a mechanism to reduce the amount of fluids retained during pregnancy and restore that pre-pregnant body fluid level. Causes of postpartum diuresis. All of these factors in the slide contribute to rapid filling of the bladder within 12 hours of birth. Diuresis begins within 12 hours after childbirth and continues throughout the first week postpartum. Normal function returns within a month after birth. Regarding respiratory system adaptations, tidal volume, minute volume, vital capacity, and functional residual capacity return to pre-pregnant values within 1 to 3 weeks of birth. Anatomic changes reside. Regarding the endocrine system, with the delivery of the placenta, there is a rapid clearance of placenta hormones. Levels of circulating estrogen and progesterone drop quickly. The prolactin hormone is secreted and is involved with lactation and reproduction. Lactation levels decline within 2 weeks for the woman who is not breastfeeding, but remain elevated for the lactating woman. Ovulation and return of menses. The 4 major hormones that are influential during the postpartum period are estrogen, progesterone, prolactin, and oxytocin. Estrogen plays a major role during pregnancy, but levels drop profoundly at birth and reach their lowest level a week into the postpartum period. Progesterone quiets the uterus to prevent a preterm birth during pregnancy, and its increasing levels during pregnancy prevent lactation from starting before birth takes place. As with estrogen, progesterone levels decrease dramatically after birth and are undetectable 72 hours after. Progesterone levels are reestablished with the first menses. Oxytocin stimulates the uterus to contract during the breastfeeding session and for as long as 20 minutes after each feeding. It also acts on the breast by eliciting the milk letdown reflex during breastfeeding. Prolactin is also associated with the breastfeeding process because it stimulates that milk production. Regarding the return of menses, non-lactating women, it returns at about 7 to 9 weeks after birth. For lactating women, this depends on their breastfeeding frequency and duration, but it returns anywhere from 2 to 18 months. Note: ovulation may occur before menses. Therefore, breastfeeding is not a totally reliable method of contraception unless the mother exclusively breastfeeds, has had no menstrual periods since giving birth, and has an infant younger than 6 months. But like I said, it is not a reliable method of contraception. Checkpoint. What should the nurse educate the postpartum patient on regarding soothing hemorrhoids? Well, the nurse should educate on stool softeners, sitz baths, and witch hazel pads. When you're helping your patient in the bathroom after delivery, as a nurse, this is a great time for a visual assessment of the area. It's also a great way to see how the patient's feeling, talk about their experience, and it's a great moment to provide education on their perineal care. This is even true for patients with cesarean sections. Colostrum is the first form of breast milk that is released from the mammary glands after giving birth, and sometimes even during the end of pregnancy. It's thickened yellow in appearance. You can see breast milk transition in the picture on the upper right corner of this slide. You might even hear nurses say, "That's liquid gold." It's because of the color, of course. It contains protein and carbohydrates, but no milk fat. It is nutrient-dense and high in antibodies and antioxidants that help build the newborn's immune system. It is only after birth takes place that breast milk is secreted instead of colostrum. This takes place within 4 to 5 days after giving birth. The following chart in this slide is from your Ritchie textbook, and it shows the lactation process. If you're not sure what lactation means, it's the process of producing and releasing milk from the mammary glands within the breasts. During the first 2 days after birth, the breasts are usually soft and non-tender. The patient may also report a tingling sensation in both breasts. This is the letdown reflex, and it occurs immediately before or during breastfeeding. After this time, breast changes depend on whether the patient is breastfeeding or taking measures to prevent lactation. If a patient chooses to breastfeed, this requires periodic motions of the newborn's jaws, undulation of the tongue, and the breast milk ejection reflex to initiate lactation. These need to be coordinated mechanisms to ensure success. Proper positioning, latching on, sucking, and swallowing are the foundation for successful breastfeeding. The American Academy of Pediatrics does recommend exclusive breastfeeding for 6 months, followed by the introduction of appropriate complementary foods and continued breastfeeding to 1 year and beyond. However, it's not for everyone. Nurses have such an important role in promoting, supporting, and protecting breastfeeding, but also ensuring the patient is comfortable with their feeding choice. In regard to suppressing lactation for a bottle-fed newborn, there have been many pharmacologic and non-pharmacologic interventions to relieve associated symptoms. There is currently no universal guideline on the most appropriate approach for suppressing lactation in postpartum patients. Engorgement is a process when breast tissue swells due to an increase in blood and lymph supply as a precursor to lactation. The breasts become hard and tender to touch. Temporarily, they are full and uncomfortable until the milk is ready. It peaks around 3 to 5 days postpartum. If milk is not removed as it is formed, the alveolar space can become overdistended, causing tender, swollen, and painful breasts. If breastfeeding, the patient can feel relief from frequent emptying of milk from breasts, warm showers, and compresses before feedings. This actually promotes the letdown reflex and softens the breast to encourage a better latch for the baby. Cold compresses should be saved for between feedings for just relief. If a patient is not breastfeeding, they should wear a tight, supportive bra, ice, and avoid breast stimulation if not breastfeeding. Other ways to reduce engorgement pain includes heat or cold applications, cabbage leaf compressions, cold cabbage I should say, breast massage, and milk expression, ultrasound, breast pumping, and anti-inflammatory agents per provider order. Postpartum diet. As I talked through this slide, please keep in mind that patients who choose to bottle feed their newborn should also be encouraged to make healthy choices. When breastfeeding, this helps fuel milk production. This includes protein-rich foods such as lean meat, eggs, dairy, beans, lentils, as well as seafood low in mercury. Patients should choose a variety of whole grains as well as fruits and vegetables. Breastfeeding patients should know that eating a variety of foods while breastfeeding will change the flavor of breast milk, and this will actually expose the baby to different tastes, which might help him or her more easily accept solid foods down the road. Providers usually recommend patients to continue taking their prenatal vitamin or postnatal vitamins during the postpartum period, even if it's a multivitamin. In regard to fluids, Patients should be encouraged to drink when thirsty or their urine appears dark yellow. Breastfeeding patients should drink a glass of water every time they breastfeed. It's important to limit juice and sugary drinks as this can contribute to weight gain. Caffeine should be limited, so maybe 2 to 3 cups a day, because caffeine in breast milk may actually interfere with a newborn's sleep pattern. Did you know that breast milk can be different colors? Not something you need to know, but it's a great education opportunity for mothers who are breastfeeding and pumping. I posted a video to Blackboard as a supplement in case you're interested. Rubella vaccine, Tdap, and additional vaccines are given during the postpartum period. Please listen carefully. No, it is not necessary for patients to avoid pregnancy for 3 months following vaccinations. And yes, Tdap is safe to receive while breastfeeding. Of course, these are with the mother's consent, of course. Nurses need to educate postpartum patients on how important it is to create immunity for their newborns. There is a link to a great supplemental video on Blackboard regarding postpartum immunizations. I encourage you to understand what should and should not be administered during pregnancy and what should wait for the postpartum period. It is important to keep our newborns safe.